Hey Piper,
Hey Elizabeth, how are
are
you?
you, are you good to share your slides? Do you see the icon at the bottom?
I think so. Let me just pull it up. Are you able to see my PowerPoint?
Yeah, that looks great.
Okay. Is there any way that I could keep like a thumbnail of like Hopin or no?
I've read that you can do, when you go to share your screen, you can do like application window or a tab or an entire screen. So if you maybe make your window smaller and then pull Hopin out to the side, I bet you can see both of them at the same time, but only share the one screen.
Okay, I think I'm just going to share my whole screen
Okay, it's kind of confusing.
and be blind to everyone.
Mhm. Okay, if it seems as if you're wrapping up around 10:05, I will just let you do your thing. And then if it seems like you're going to go over, I will let you know that you have 5 minutes left, just so we have room for questions and a transition.
I was on mute when I said thank you. Okay.
Okay.
All right, it's 9:50, so I'm going to go ahead and get started. Good morning, everyone. My name is Piper Yerger, and I'm a nurse home visitor with Caring Nurse Family Partnership in Charlotte. The research that I'm presenting today was actually my master's dissertation, which was a master's in global health and development that I got in 2018. But since then, I've worked with my supervisor as well as a couple other academics to update the research, and we just had it published in the British Medical Journal. So the title of the research is Barriers to Maternal Health Services During the West African Ebola Outbreak, a literature review. And the three countries that I reference in the title are Guinea, Liberia, and Sierra Leone. These were the three countries that were primarily affected during the 2014 outbreak of Ebola in West Africa. So when I turned to the literature and began to learn more about routine maternal health services during the Ebola outbreak, what I learned was, what I found was primarily quantitative data. So there is fairly robust evidence available of significant reductions in the uptake and provision of maternal health services during the Ebola outbreak. So just some examples here. In Guinea, we saw a 59% reduction in the first antenatal care visit, a 62% reduction in facility-based births. Similar in Liberia, utilization of antenatal care and facility-based births were at less than 14% and 9% respectively of pre-outbreak usage. And in Sierra Leone, there was a 22% reduction in postnatal care. And Jones and colleagues actually estimated a 34% increase in maternal mortality, the maternal mortality ratio, due to reduced access to services. So having learned of this significant reduced access to routine health services, maternal health services during the Ebola outbreak, I really wanted to learn why. So we know that timely access to skilled maternal health services is a really critical component of preventing maternal morbidity and mortality. So I wanted to learn the reasons why women weren't getting the services they need during the Ebola outbreak. Two, with more frequent outbreaks of Ebola occurring since 2014, as we saw in the Democratic Republic of Congo, it's essential to not only quantify the negative changes in usage, but also investigate the underlying causes of those negative changes to inform policies and interventions. So as you saw in my title, Our aim in this research was to identify and describe barriers to the uptake and provision of maternal health services during the 2014 to 2016 Ebola outbreak in Guinea, Liberia, and Sierra Leone. And you may be wondering what exactly we mean by maternal health services. So we utilized the WHO's very general definition, which is just any health service necessary to promote health, manage complications, and prevent morbidity and mortality related to pregnancy, birth, and the postpartum period. So specifically things like skilled birth attendants in facilities, antenatal care, and postnatal care. So this was a scoping review of the literature. The databases that we used to obtain our peer-reviewed scholarly literature was PubMed and Web of Science. And although this was a scoping review and not a systematic review, we did use a systematic approach to develop our search terms, inclusion and exclusion criteria, and we used the PRISMA framework to screen our literature based on title, abstract, and full text reading. So for the sake of time, I won't detail the specifics of our search terms and inclusion and exclusion criteria, but you can find that in the full text publication. So additionally, we included gray literature. We wanted to include research and perspectives from key actors that were on the ground and responding during the Ebola outbreak. So we searched the websites of organizations like WHO, MSF, Oxfam, and the Ministries of Health for Liberia, Guinea, and Sierra Leone. And finally, we hand searched the references of all the literature we gathered just to make sure we didn't miss anything in our searching. So we did use an existing framework to analyze our literature. So Jacobs and colleagues they wrote a framework for healthcare access in low-income countries, and they look at healthcare access sort of in 4 categories: geographic accessibility, availability, affordability, and acceptability. And they further dichotomize that into supply-side factors and demand-side factors. So you'll learn later in the presentation how all of these factors were disrupted during the Ebola outbreak, resulting in reduced access to maternal health services. So we included 19 papers, 16 of which came from our database searching and 3 came from our hand searching. And we identified 26 barriers to maternal health services, both supply side and demand side, in the literature. And patterns in the literature really yielded 3 themes. So the first theme was fear and mistrust. Our second theme was health system and service constraints. And our third theme was poor communication. So instead of detailing each of the 26 barriers individually, I'll kind of discuss them all under the arch of these 3 themes. So our first theme, fear and mistrust. 15 of the 19 papers reported fear and mistrust as barriers to maternal health services on the supply and demand sides. So in terms of the demand side, the literature evidenced that pregnant women feared multiple aspects of engaging with healthcare, including acquiring Ebola from health facilities, being transferred to an Ebola treatment center. They feared the appearance of healthcare workers in personal protective equipment, or PPE. They feared receiving disrespectful care, and they feared being refused altogether. From a supply side, healthcare workers primarily just feared acquiring Ebola from patients and transmitting it to their families. And this is particularly relevant for maternal health services due to the bodily fluids that are expelled during childbirth and the contact needed for other maternal health services. So this really diminished healthcare workers' motivation to continue to provide maternal health services during the outbreak. And fear, particularly on the demand side, was facilitated by an existing public mistrust of the government and government-backed healthcare, which was really facilitated as rumors regarding Ebola and the intentions of Ebola responders proliferated. So it's outside of the scope to really dive into why the mistrust was there, but it's important to acknowledge that it was. So examples of rumors included that healthcare workers were actually injecting people with Ebola or spreading Ebola intentionally for money or other reasons. There was a rumor that healthcare workers were indiscriminately transferring patients to Ebola treatment centers, again, for money. And there was also a rumor that Liberians were being killed intentionally so that Westerners could have their kidneys. So the details differed, but these rumors were very serious barriers across all three countries to women wanting to go to health facilities and get care during their pregnancy. So our second theme was health system constraints. So a lack of resources for maternal health services such as equipment, drugs, supplies, personnel, and most critically PPE was reported across the three countries. And health resource scarcity in these three countries is an issue in the best of times. So it was exacerbated during the Ebola outbreak as resources got diverted from routine services to supplement the Ebola response. So some health facilities closed, some reduced their hours. There weren't enough healthcare workers to provide maternal health services. And this was because of a number of reasons. So some healthcare workers abandoned their posts because they were afraid of getting Ebola from pregnant and laboring women. Some were transferred to Ebola treatment centers. And also healthcare worker death from Ebola was a barrier to maternal health services. So a really interesting modeling study postulated increases in maternal mortality of 38% in Guinea, 74% in Sierra Leone, and 111% in Liberia due to all of the healthcare workers that died from Ebola. So that was a really important factor. There just weren't enough healthcare workers to provide services. Financial barriers were addressed in a few papers. There was an increase in informal fees that pregnant women were charged. They shouldn't have been charged anything for services. And also there was a disruption in payment. So some healthcare workers stopped getting paid. So they stopped providing services. And as mentioned, there was a gap in the number of healthcare workers available. This was partially filled with traditional birth attendants or TBAs. And TBAs aren't technically allowed to perform births, that's forbidden. But this policy was not enforced during the outbreak. TBAs were more trusted by pregnant women and less likely to discontinue services due to fear. So they filled that gap. But the issue of them not having the right equipment, not having the right training about Ebola and infection control, definitely played a negative role and created a barrier to skilled facility-based maternal health services. Last, we have a no-touch policy. So Ebola is transmitted via contact with an infectious individual. So a no-touch policy was enacted across health systems, which posed a barrier to maternal health services. So healthcare workers didn't or weren't allowed to touch patients until they were proven EBV or Ebola negative. But this was an issue because the symptoms of Ebola often mimic the symptoms of obstetric emergencies. So pregnant women, even if they were having an emergency, had to wait until a test came back negative. They had to sit in an Ebola treatment center before being transferred to the maternity unit. So this increased waiting times, and it risked the life of pregnant women and their babies. And some pregnant women may opt out of going to the facility at all under the assumption that they wouldn't be touched once they got there. And confusion around this policy contributed to healthcare workers refusing pregnant women at the door. So our third theme, poor communication. This poor communication happened at the community level, health system level, national, and even international level. So as discussed, rumors and misinformation at the community level posed a real barrier to maternal health services. At the health system level, healthcare workers just didn't have the knowledge or training for PPE, to put on PPE and to care for patients during this Ebola time. So it was a really significant barrier for them continuing to provide healthcare because they just didn't have the knowledge or education around that. Midwives often heard about Ebola from informal sources rather than government or NGO organizations, which again increased the spread of misinformation and actually increased fear. And even when midwives had the training and the clinical guidelines, the no-touch policy and other infection control policies prevented them from providing the care that they really needed, which was a huge barrier to maternal health services. So like all research, ours had some limitations, but I'll skip this for the interest of time and talk a little bit about relevance to COVID-19. So although our review was specific to the 2014 outbreak of Ebola in West Africa, the lessons learned may certainly have broader relevance for outbreaks which incite fear and health system disruptions. Fear of infectious diseases certainly preceded Ebola, and the health systems ill-equipped or ill-prepared to manage epidemics are certainly not unique to West Africa. So the current COVID-19 pandemic has already been projected to result in a significant increase in maternal mortality based on many of the same barriers that we identified in this paper, which is really interesting. So pregnant women aren't getting the care that they need. The access to healthcare is disrupted, just like it was during Ebola, and it's happening here with COVID-19. So it's really important to apply historical learning to mitigate the indirect impacts of an infectious disease outbreak, and to inform the development of resilient health systems. So I didn't really have time to go in depth, do an in-depth discussion of our results and recommendations for future research or future outbreaks. But the message to drive home is that we really need to address patient and provider fear and mistrust if that's an issue. We need to work together to strengthen health systems to simultaneously provide routine health services and respond to infectious outbreaks. And we need to better coordinate education levels. There needs to be sensitization and education at the community level. There needs to be education and training at the health system level, and our national leaders need to have that training and education as well. So like I said, we were really excited to get this published recently in the British Medical Journal. So I included a link in case you wanted to read the full text publication. Here's my contact information if you want to reach out to me to discuss it anymore or talk anything public health. I'd be happy to get that email. Here's the references I used just for this PowerPoint. And again, thank you so much for joining. I wish we could all come together in person, but I appreciate everyone that's here virtually and everyone that organized this event. So thanks, everyone.
Thank you, Piper. That was great. If you have any questions, feel free to leave them in the chat. Piper, the one question that's been asked is about COVID, which you touched on.
I did.
I would also, if you're able, I think putting the link to the journal article in the chat would be useful as well.
Okay. I will do that now. And just to expand a little bit on what Amy asked, so at the time of the write-up of the paper, that article by Roberton, I don't believe she addressed fear and mistrust. Her primary projections on the increase in maternal mortality was related to other barriers to maternal health services, such as people not being able to go, people being rescheduled, their clinic being closed, maybe they can't be seen in person, things like that. So I can link that article as well.
That'd be great. Great, thank you.
Thank you.
Okay, everyone, as Amy said in the chat, our next talk is with Lindsay Yates at 10:10. moving towards reproductive justice and a state-funded maternal and child health program. So we will see you there.